Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from China, Professor Lu Miking. Prof. Miking is the Director, Department of Neurosurgery, Shanghai General Hospital, China. He is the Vice Chairman, Neuro-Oncology Professional Committee, Shanghai Anti-Cancer Association, and he was a previous member of the WFNS Skull-Based Surgery Committee. He is a vastly experienced neurosurgeon with over 30 years and has performed over 8,000 cases of complex intracranial tumors, cerebrovascular diseases, spine, and other neurological diseases. His surgical expertise of interest are endoscopic and minimally invasive microscopic techniques of our complex skull-based tumors, including pituitary adenomas, acoustic neuromas, and brainstem tumors. The speaker for the second session of today is our honored guest from Cape Town, South Africa, Professor Graham Fijian. Prof. Fijian is the Director of Neuroscience Institute, Helen Morris Morberger Professor, and Head Division of the Neurosurgery at the University of Cape Town, South Africa. As a pediatric neurosurgeon, his clinical interest lies in the congenital disorders such as spina bifida and functional conditions such as spasticity and epilepsy. Research questions that interest him include the prevention of neural tube defects by folic acid, in particularly understanding the neurobiology and developing sustainable strategies through food fortification and the evaluation and management of spasticity. He is a noted author with several publications in various peer-reviewed journals, and he was also the president of the previous WFNS meeting which was held in Cape Town. He is an invited faculty to various workshops and conferences around the world, and we are extremely honored to have him today at our webinars, and today he'll be talking about spinal dysraphisms. The chair for the first session of today is our honorable guest and senior faculty from India, Professor Rupesh Kumar. Prof. Rupesh is the Director of Neurosurgery at the MGM Healthcare, Chennai, India, and is a distinguished surgeon with over 20 years of experience with expertise in managing complex brain and spinal tumors, minimally invasive cranial surgeries, and cerebrovascular surgeries. He is associated with some of the most premier medical institutions in the country, such as NIMHANS and JIPMER, and he holds several important positions in the NSI, which is the Neurological Society of India, like being the convener of the Young Neurosurgeons Forum, and he is also the secretary of the Skull-Based Surgery Society of India and founder secretary of the Society of Intraoperative Neurophysiology and executive committee member of the Neuroendoscopy Society of India and Indian Society of Neuro-Oncology. He is a noted author with several publications in impactful journals, and also he has authored several book chapters in renowned textbooks. He has been honored with several awards for his outstanding contributions to neurosurgery in India, and we are extremely grateful to him for accepting our invitation to chair the session of Professor Lu Miking. The chair for the second session of today is our honorable guest from Germany, Professor Concesio Di Rocco. Prof. Di Rocco is the Director of Pediatric Neurosurgery, INI, which is the International Neuroscience Institute, Hanover at Otto von Guericke University, Germany. He is also the Consultant Department of Pediatric Neurosurgery, Catholic University Medical School, Rome. He was the past chairman of the Education Committee of the WFNS, and he was the chairman director together with Professor Maurice Chalks of the International Master Course of Chinese Pediatric Neurosurgery at the Beijing United Family Hospital and Clinics and Capital Medical University, China. He was the past president of ISPN. He has written several articles in reputed journals and book chapters, and we are extremely grateful to him for accepting an invitation to chair the session of Professor Graham Fijian. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Professor Rupesh Kumar.
Good morning, good afternoon, good evening, everybody. At the outset, thank you very much, Dr. Raja and Dr. Boone, for having us today for this good ACNS meeting. And so the first topic, Professor Miking will be speaking on the hearing, the facial nerve preservation strategies in vestibular schwannoma. As we know, vestibular schwannomas are surgically challenging just because of one reason, the preservation of the facial nerve. Once it was quite considered as very challenging, but there are a lot of renowned surgeons all over the world have now mastered this technique, and they have contributed and they have transformed this technique to the younger colleagues. And now the facial nerve preservation in vestibular schwannoma has become a standard of care. From the tumor-centric approach, now we have gradually moved on to the nerve-centric approach, wherein the preservation of the facial nerve becomes the utmost priority. And at that cost, we may leave behind a thin rim of tumor on the facial nerve so that we also don't damage its vascularity, so that it's not just about the anatomical preservation, but more important is the functional facial nerve preservation. So there are a lot of ambiguity and a lot of technical changes which when to do the IM drilling, whether IIM drilling is required, where to locate the facial nerve, whether it should be from the medial end or the lateral end, and the epinurium, whether the facial nerve is separated by any arachnoid layer. A lot of other changes are there. But then we would like to hear from Professor Making on this particular topic as how to preserve and what are the strategies to preserve the facial nerve in vestibular schwannoma. And we look forward to hearing from you, Professor. Thank you very much for joining us, and we're eagerly waiting forward to hear from you.
Hello, everyone. It's my great honor to be here to share my preliminary experience about acoustic neuroma. Today, my topic is analysis of key factors influence facial nerve preservation in large acoustic neuroma surgery. A total of 208 cases were compared with the previous years in 2023. I'm from the Shanghai General Hospitals. It's first, as acoustic neuroma is a benign tumor, but complex and can be catastrophic. I would like to mention these two outstanding experts in acoustic neuroma surgery. One is ENT House, and another one is neurosurgeons, Hesburgers. They combined to introduce microscope technique into acoustic neuroma surgery, and the pre-operative mortality rate has been greatly reduced. The safety has been improved, and the tumor resection rate and facial nerve functions preservation rate has been significantly improved, and laying a solid foundations for late acoustic neuroma surgeons. The modern development and trend in the field of acoustic tumors. Current trend in the treatment of acoustic neuroma requires surgery to ensure tumor resection and preservation of facial nerve function, preferably to grade 2, regardless of tumor size or patient age. This trend has put forward higher requirement for the treatment of patients with large tumors, prompting patients to choose higher skilled doctors and medical teams. To meet this trend, surgeons must be continuously optimize and improve their surgical methods, including reduce surgical trauma, employ advanced surgical technique, and minimally invasive methods to minimize trauma to the patient. Accelerate post-operative recovery, improve post-operative care and rehabilitation to facilitate rapid patient recovery, and high facial nerve function preservation rate to delicate operations during surgery, ensure a high level of anatomical and functional preservation of the facial nerve. And how about us? And I began surgery for acoustic neuroma in 2002, and I started by Professor Louis Chen in Changzheng Hospital in Shanghai, and also Professor Zhang Junqing from Qingdao Hospital in Beijing, and also Majania Samijas in Hanover Uni. And I have done the, more than 1,000 cases of acoustic neuroma since then. And so overall, incidence of vestibular schwannoma is about 3 to 5 per 100,000 people's incidence increased with age. As the median age of onset was 50 years, with the same incidence on both the left and right side. The unilateral acoustic tumors occur in more than 90% of cases, and bilateral acoustic tumors are common in NF2. In these presentations, 216 cases of acoustic neuroma in 2023 and 311 cases of acoustic neuroma in 6 years from 2007 to 2020, including 103 and 105 cases with diameter greater than 3 centimeters, respectively. And we used to retrospectively summarize and compare the case state of a single team in North Shanghai General Hospital. And here is the tumor size from 2017 to 2022. And in our team, we have done 311 cases of acoustic neuroma, and the diameter more than 3 centimeters. They are 105 cases. And in 2023, we have done 214 cases of acoustic neuroma, and the large one is also 101 cases. So these two data cases we will compare together with improved surgical techniques. Here is an image, part of the image of acoustic neuroma. This is also the large one, and this is the large one, the case methodologies. The higher correlated factors affecting the preservation of the facial nerve functions was compared and analyzed. We think the tumor size, degree of adhesion between facial nerve and the tumor, and the position of the facial nerve and the degree of the facial nerve compression, and the widening at the path of internal acoustic canals, and the texture of the tumors, etc. Individual separation technique combining sharpness and bluntness are adopted when needed. And we use the suboccipital sigmoid approach, and this is the mostly we use. And some we use the middle skull-based tumors, a middle skull-based approach in a few facial neuromas that invaded in the middle skull base. And this operation was mainly used the microscope and endoscopic assisted when necessary. We during this case, we are constantly reviewing and improving the treatment, our technique in order to achieve the better result. Here, we are usually commonly use this posterior keyhole approach to the sigmoid sinus, where you see these incisions. This is the bone windows, and all the surgery we use the electrical physiological monitoring, and where this is the Medtronic machine, and where commonly use the free EMG techniques, and we will see the different wave. And we are specially recommend the programmed section procedures, then step by step. This we we will debulking in the path of acoustic IAC, and then we will drill out the posterior wall of the canal and remove this part of the acoustic tumors and dissect the facial nerve and the cochlear nerve from the tumors, and then we will use the clockwise from the lower polar of the tumor, then to the middle cerebrum medulla, and the superior polar. Then after that, we will use the brainstem decompressions, and finally to the tumor carving from the facial nerve. The facial nerve dissecting always leaves the final stage. Here is an example. This is a typical large acoustic neuromas. This is before the operation, this is after the operations. And first, we debulking the parts of IAC, and then drill the acoustic posterior wall and remove this part of the tumors, and then the inferior polar of the tumor, and then to the superior polar, and then to dissect the brainstem interface, and finally to remove the tumors from the facial nerve. And let's see the video. We are recommend the programmed resection procedures. All the tumors, we are abide this programmed resection procedure. This is the case of the 60 years female and hearing loss acoustic neuromas. And after the bone window has been formed, and we insect the dura, then we will debulking the parts of the IAC, and then we drill the posterior wall of the IAC, and after then we will use the sharp dissect the cochlear nerve, and then to the inner layer to carefully remove, and then we go to the third stage of the inferior polar, and remove the tumor piece by piece. And after the superior polar, then we go to the final stage to dissect the tumor from the nerve. Then this is the typical programmed resection procedures. And during the procedures, we are paying much attention to the treatment of the tumors of the internal, getting more and more attentions. And we found the internal auditory canal, the residual tumors is often, if it's a remnant, it often becomes the root of the cause of tumor recurrence. So it is necessary to ensure the tumors in the IAC, inside ICC, can be removed. But sometimes the inside of the IAC is destruction is very different. Some is just enlarged, but some is irregular. So we need the assisted by the endoscopic to see the remnant of the tumors inside IAC. This is the 26 years old female and with a large acoustic neuroma with a diameter of the 4.4 centimeters. And but he has a recurrence of the resident tumors in the IAC. And this is before the operations, and we do the operations, and most of the tumor has been removed. But we find out the 3 years later, the remnant in the IAC is regrowth, and we use the endoscopic assist and to find out this part of the tumor is removed. And we also use, if the tumors inside ICC is very deep, we will use the endoscopic assisted. So this is papers we published in Frontiers in Oncology. And the degree of the bone destruction of the IAC is different. The posterior wall of the IAC and the degree of the gasification of the is also very different. You can see here, this is a solid, and here is gasifications. So just like this case, if we remove this part of the tumors, and we need to remove the posterior wall of the IAC. And if we haven't tightly repaired this part of the bone cells, so maybe it will CSF leakage after the operations. So we need, when we, after we removed the tumor, and we need to carefully repair the posterior wall, and we use several layers and use the muscles and the artificial durasts and with the glue and repaired the posterior wall of the IAC. And intraoperative facial nerve monitoring is very important. It's very important. So when we do the operations, we will continue to ask if there wave, any wave with assistant. And during the operations, the key factors of the facial nerve, the position of the facial nerve and the width of the facial nerve is very important. I will mention it later. If the facial nerve is uppolar, the facial nerve was stretched and become longer. And if the facial nerve is become widened, so it is also have a high risk of the damage of the facial nerve functions. And here is the result. And we have a total resection rate of 88.4%, and the near total resection is 10%, and also have some subtotal resections. And the hematoma in distant site, here is a 0, and the cerebral hemorrhage have 1 cases. And in 2023, and we have a total resection rate of 85 and the near total resection 15%, and also have one case of hematoma in distant site and one cerebellum hemorrhage. And how about this CSF leakage? And in 2000, from 2017, previous 6 years, and there are 20 cases, and about 6.4% of CSF leakage, granular, and just lay bed for 2 weeks, and it's no need to the operation room again. And in 2023, there are 4 cases, and occupying 2%, and lay bed for 2 weeks, and it's none to the operation room repair again, and 3 cases are subcutaneous fluid. And this is related to the second operation. The first operations, they are due in another hospital. And intracranial infections, there are 17 cases in previous 6 years, and 4 cases in the last year. And the infections are cured by the drainage through the lumbar pool. And the factors influence the tumor resection and the facial nerve. And we think the key factors related to these 6 factors. We strongly recommend programmatic resection strategy because it's stable and safety and it's effective. And the facial nerve, the location of the facial nerve, if it's located in the upper polar, it is very susceptible to injury. And so we must must need to ensure where is the facial nerve located, and whether the facial nerve is bundled or the umbrella shaped. It is also key factors. If we found the facial nerve is umbrella shaped, so it is high risk of the damage. High damage of the function of the facial nerve after operations, and also the texture of the tumors and the degree of adhesion with the facial nerve. It is also very important factors, and we are always to search for and the retention of the membrane structures on the tumor surface. This is the best way to preserve the facial nerve from the tumors. But sometimes the membranes of the structures does not exist. And of course, the larger of the tumors, the more difficult it is to preserve the facial nerve function and hearing functions. And the position of the facial nerve relation to the tumors in our data, we find the upper polar, there's in the upper positions, they are occupying 34%, and it is very easy to have a higher risk of the facial nerve function damage. And the forward up is 43%, and this is the second risk. And the front down and the lower polar, so the facial nerve is short, and we can easily find and preserve it. Now, the width of the facial nerve is a very important key factors. key factors. If the pulse of the widest of the facial nerve is equal or 2 times widest of the facial nerve in the middle of the IAC, and this if the widest is too compressed, too thin, and enlarged, and it is high risk to have the damage of the facial nerve. And also the adhesive degree is also can affect the facial nerve's outcome. And the presence or absence of the memory structures. And during the operations, we are need to seek the memory structures during the operations. Here is a video of the large acoustic neuromas. When we do the texture of the tumors is different. This kind of the tumors is full of fat, so the membranes is very difficult to find it. So during the operations, we recognize if we can find out this membrane, it's have a high risk of the damage to the facial nerve functions. So we use the sharp dissections to remove the tumors, not to seek the total resections. To near total resections for this case is the best choice. So this our strategies to preserve the facial nerve. This case, we also got the grade 1 of House-Brackman grade systems. And this is a total nerve functions. This is the result from the previous 6 years. For the large tumors, we also have a grade 1 and a grade 2, and for the giant tumors, and we only had a grade 1 is 33%, and the previous. And when we realized the key factors, so we improved our technique in 2023, and the facial nerve functions, the grade 1 is highly elevated and preserved, and we became from the 33 to 67% of grade 1 for the giant acoustic neuromas. So this is previous 6 years and this is last year's, so we get a better result. Here is another case of the giant tumors, and these tumors. This is 42 years old female, and the diameter is 5.1 centimeters. And we did these programmed resection procedures and debulking and removes the posterior wall, and also finds the facial nerve and the cochlear nerve. And finally, we debulking, and since finally we dissect the tumor from the facial nerve and the cochlear nerve. And this is a post MRI image, and this tumors is near total resection, and to our surprise, his facial nerve is grade 1, and also he have a good hearing loss. And he telephoned with his daughters. Discussions. There is a hot controversy about the large and acoustic neuromas. We do have the strategy total resection or the near total or subtotal or partial resections. For the Kuss grade 4 tumors, brainstem compression and cranial nerve displacement, the maximum tumors diameter is always greater than 3 centimeters. And the main goal treatment, decompression of the brainstem and cranial nerve preservations. And complete resection may carry a risk of loss and further deterioration of cranial nerve functions. And the complete resection cannot be safely achieved if complete resection cannot be safely achieved. We mentioned they have a high score of the key factors, risk of the key factors. So we will choose near total resection is prudent. Residue tumors, maybe we can follow up. If it is occur, we can use SRS or SRT. And the radical near total resection and the near total resection, it is suggested by the 1990s last centuries. And with a small amount of the tumors remain due to tight adhesions of the facial nerve or brainstem. Near total resections refers to the wide resection of the tumor, in which the margin of the part of the capsula that are adherent to the brainstem and the cranial nerve are left. So how about the recurrence of this kind of strategy? And in our experience, there are very few cases will reoccurrent. So we are recommend, if there are higher risk of the key factors, we are recommend the radical near total resection of acoustic neuroma. So the preservation is very good of the facial nerve is very good. So this is a fourth case of the female as 25 years old, and his diameter is 4.4 centimeters, and this tumors is involved into the brainstem, and we also find this is a vessels here, vessels located in the path of IAC. So during the operations, so it is very difficult to remove these ACA arteries. So we remove the tumors in different part of between the vessels, and then remove the tumors and drill the posterior wall. And remove the part of, and here is a facial nerve. facial nerve. It's bundled. So the final facial functions can be preserved well. These post-operation 3 months, and his facial nerve is preserved good. This also have a 20-year-old male, and he has a hearing loss, and a very large one, and the tumors is larger than 5.4 centimeters. 5.4 centimeters, and here is the result, and some remnant here is the brain stems, and his facial nerve is also good. Yeah. This case is very difficult because the tumors is invaded in IAC and destroyed very large. And he is only a 22 years old female. He is a student, undergraduate student from Tsinghua University in Beijing. And his tumor is 3.6 centimeters. And during the operations, and we also find the AICA branches of AICA just handed during the operations, and it is ruptured. It is ruptured during the dissections. So we have no choice to coagulate. Then we remove the tumor piece by piece according to our programmed dissections. This is the final stage. We remove the tumors. Final stage. And the facial nerve we preserved. And then we repair the posterior wall. And then we have anastomosis of the AICA. And it is, this is the final. Now, the two vessels have an end-to-end anastomosis, and the vascular anastomosis is complete. And this is after the operation. There is no infections of the cerebellum. And his facial nerve is also preserved well, grade 1 of house black man. And to our surprise, his hearing is partially recovered when he told us he can telephone with this ear. It's also to our great surprise, and he is to take part in his graduate ceremony. This is the last case, and we also do we use our programmed resections, and also the large one, and we remove the near total removal these tumors, and his facial nerve is very good. This is a pregnant ladies, and finally, I'd like to give a summary. The key factors influence the roughness of the tumors. We think we suggest the programmatic resection strategy is very important. It is optimize the facial nerve and keep the whole operation stable and safety and efficacy. And if we realize that the facial nerve is located in the upper polar and it is very susceptible to injury. And so we need to know where is the facial nerve. And after we have the second stage, after we drilled the IAC and remove the tumors in IAC, then we can know. So where is the facial nerve? Is it in the upper polar or forward, front, or the lower polar? Then we will have different strategies. And whether the facial nerve is bundled or the umbrella shaped, it is also very important. If the patient is umbrella shaped, it is have higher risk of the damage of the functions, and also the texture of the tumor and the membrane structures of the tumor surface. It is also very important key factors to guide us how to remove the tumor without damage to the facial nerve. The procedure step by step to remove the tumor, each step must be in place. It is very important to protect the facial nerve functions and the hearing functions. It is also very effective means to remove the tumors. Once the facial nerve is widened and thinned during the operations, also it is in the upper polar position of the tumor. It is also very dangerous signal and is a more prudent choice to use radical or near total resection of the tumors. Resection of the posterior wall of the IAC can increase the chance of the total tumor resection, and the development of air chambers in posterior wall of IAC is high risk factors for post-operative CSF leakage. So we need to have several layers to repair. And the neuroelectrical physiological monitoring is very important. And every hand of it is analyzed. So this caution is a continuous alarm, insisting that every patient's facial nerve function is preserved to grade 1 is the driving force behind us to continuously improve our surgical technique. Here is 2 months of the operations in our hospital. They have a smile face. That's all for my presentation. Thanks for your attention.
Professor Making, thank you very much for this excellent lecture on facial nerve preservation techniques in vestibular schwannoma. You have showed very beautiful images of large and giant schwannomas and a very good functional outcome in these patients. So first of all, we should congratulate for your good work. And you have clearly told that by age, with time, you have improved your results and you have achieved whatever best possible in the last couple of years more. Yeah. We have some questions so we are clearly insisting that the location of the facial nerve is very important. And you mentioned that the upper pole, the closer it is to the upper pole, the risk of the damage is quite high. Yeah. So Do you think it is because of that tumor, the nerve is very much stretched? Is that the reason why, if it is in the upper pole, you feel that the risk is higher?
Facial nerve in the upper polar is easier to damage. So when we do the operations, so when we recognize the facial nerve is in the position of the upper polars, so we will leave the last stage to dissect it. And the sharp dissection is recommended to. Sometimes we will left some thinner and remnant to preserve the facial nerve.
Do you do the tractography preoperatively to look for the position of the facial nerve?
Yes, we do some cases. It can show it, but sometimes it doesn't work.
Okay.
Because the facial nerve is very thin in the large tumors.
Okay. Yeah. So at what stage of the procedure do you drill the IAC? Initially itself you drill the IAC, or once you have decompressed internally, you do the IAC drilling?
Timing, yes. After we are in the earlier stage, when I removed part of the tumors in the path of our IAC, then I will drill the posterior wall.
Okay. Yeah. You are mentioning about some membrane.
Yeah, membrane.
Yes. What is that membrane? Yeah. What do you really mean about this membrane?
Yes, maybe it is part of the arachnoid membrane, and also it is the nerve vessels membrane.
Okay.
But we didn't find out not all of the tumors have the membranes. There are only maybe 40%. They have the membrane, and a part of them only have partially membranes. Yeah.
Okay. Yeah. So the other thing is, I could see that in your series, there are a lot of tumors which are less than 2 centimeters. You do surgery. Yes?
Yes. In my case, I will do 80 cases, maybe 70%. No, 70 cases annually.
So when do you consider gamma knife? Because in our country, less than 2 centimeter, we prefer upfront gamma knife.
Yes, because the gamma knife is also recommended for the small acoustic neuromas. But when we consider the long-term result of the young patient, they have a very long time to live. So if we do the gamma knife, the first one is hearing loss. The hearing preservation, it will lose after 5 or 6 years. Most cases. And the second, the tumor recurrence is also exist. For the younger patient, if the tumors is growth rate is higher than 3 millimeters per year, we doesn't recommend to do the gamma knife. The result of the operation is very good in our experience, in our cases. So there are many younger patients when they find out the acoustic neuromas, they come to consultant with us and ask my advice. And I will recommend it is better to to do the operation than the gamma knife. If the patient is over 70 years old and or have the fundamental symptoms, fundamental the other complications, we will recommend to gamma knife.
Okay. Yeah. So what percentage of these patients do have NF2, the neurofibromas type 2?
Or AF2.
NF2.
Yeah, AF2. In the last year, I do 14 cases of NF2, and some of them say it is very difficult to choose. It is depend the choice of the patient. We will give them advice. If when they come to see us, they both have the larger tumors. So if the one side has the hearing, we will preserve it. We will first to choice the no hearing side. We'll do the operations. Yeah. If after that, if the patient he asks to do another side, we will do it. And sometimes we are also face the case, just have the hearing with the tumor side, and the other side has no hearing. So it is a great challenge for us. So we will use the near total resection of the tumors to preserve the hearing for the tumor side, to do our best to get the better result. For the time limited, I didn't show some NF2. I have a good NF2 result. Some of them have a good hearing preservations.
Okay. Fine. Okay. So, Professor Making, thank you very much for this elaborate discussion, and we are equally thrilled to hear from you, and we have learned a lot today from you. Thank you very much for this.
Thank you.
Thank you very much. We have our honorable second speaker, Prof. Graham Fusion, who has joined us. We're extremely grateful. So we'll move on to the second session, but before that, I would like to inform our viewers that this has been broadcasted on WeChat, YouTube, and Zoom. And thanks to Professor Shubin for broadcasting this on the WeChat channel. And we have, as of now, 430 people who have logged in through all different channels. So thank you very much. Now we'll move into the second session, and I would request our Honorable Chair, Prof. Concesio Diroko, to say a short introduction and invite our Honorable Speaker, Professor Graham Fusion, for his lecture.
Good morning to all. Good evening to Professor Graham Fusion. And I see an exotic panorama behind you, which is not usual, no books, but really beautiful image. And then, so you are going to illustrate a big problem, especially for the developing country, because it's economic burden and its social importance, that is the congenital malformation of the spine. And I think that you are in the best position to discuss this, because you are combining the technical ability in treating this, and also you face the problem that the children surviving can pose to the family, especially in countries where the health delivery system is not so developed. So please tell us what you think about.
Fantastic. Thank you, Etcher. Hi, good afternoon or good evening, everybody. Thank you so much for the invitation, and it's a real honor to be introduced by an old friend of mine, Professor Diroko. We go back a long way, Etcher. But firstly, just greetings from Cameroon. I had to unexpectedly fly here to Yaoundé for a conference, and it's a little bit noisy outside, so I apologize if there's too much background noise. And congratulations to India, Raja. We finally got to meet you in a World Cup final, and we got taken out by the greatest catch in history. But wow, it was an amazing game. So to all of you out there, part of this webinar from India, congratulations. It was a spectacular game to watch. And it's always a real treat to be part of these ACNS gatherings. Professor Kato has done so much. In fact, more, I think one can really say more than anybody I can imagine, to develop neurosurgery around the world. And obviously, ACNS has been a particular passion, but I wanted to just include this picture of Professor Kato teaching on a course in Abuja in Nigeria a few years ago, and you know, her commitment and the commitment of ACNS to developing neurosurgery around the world is, I think, really a testament to Professor Kano's legacy that led to the establishment of ACNS. So thank you so much for everything you do. And it's wow. So you were president, the very first ISPN meeting I ever went to in 1995 in Chile. That was the start of my academic journey in pediatric neurosurgery. And I had a look at this paper last night, actually, and it's interesting. Your topic for your presidential address was the significance of an international society, and a really, really interesting reflection on where kind of neurosurgery is going around the world and what the role is of all the different societies. And I really enjoyed reading it. And thank you for everything you've done to help build organized neurosurgery over the years. So I've been asked to talk about spina bifida, or spinal dysraphism. I'm going to start off just with a couple of perspectives. I think it's important, as Professor DeRocco said, it's a very common condition, particularly in developing countries. And it's, in fact, the commonest birth defect that involves the central nervous system. And as I think everybody in this webinar knows, the key problem here is abnormal closure of the neural tube. And I'll come back to that just now. But probably more important than that is the fact that it's largely preventable, not just through folic acid, but also there are various things that we can do that will reduce the incidence. And I think one of the most important to always remind neurosurgeons is to think about stopping valproate in women of childbearing age. It's truly tragic when you see a valproate-induced myelomeningocele in a young woman with epilepsy who didn't know of the consequences of continuing to take the drug in pregnancy. But even if you miss the opportunity to prevent the condition, this condition is compatible with an excellent quality of life, and I think that's a really key message to convey to all of our colleagues across all the other specialties that come into contact with children and adults, for that matter, with spinal dysraphism. Where we really have a role as neurosurgeons is initial treatment. And it's incredibly important, and I'm going to talk about this again just now, that what we do really determines the trajectory of these children's lives. And if we mess it up or we make the wrong decisions early on, they're destined for a life of misery. And we also have to play an important role, I think, as advocates for these patients throughout their lives. But given that many of the people in this webinar, I guess, are not pediatric neurosurgeons, just a couple of things that I also want to highlight. The first is that when you are a neurosurgeon looking after children, you need to bear in mind that the clinical assessment is different. And it's very easy to kind of make an assumption that a kid is normal if you don't examine them properly. And particularly when it comes to conditions like spinal dysraphism, you may miss quite subtle abnormalities that can be really important in terms of the long-term functional outcome. You've got to think twice before imaging, and not just because of the risk of radiation if you're doing CT scanning, but because of the hassle of anesthesia if you're doing multiple MRI scans. And you've got to take development into consideration. And we've been following up a cohort of children who had rhizotomies done in the early 80s, and they're now kind of close to 60 years old. And it's really actually a miraculous aspect of our careers that we'll operate on children who are kind of newborns or 1 or 2 years old, and then we have to bear in mind that they may be around for many, many decades, and you've really got to factor that into your clinical decision making. But another important perspective is that although pediatric neurosurgery is clearly a very important specialty for the management of children with conditions like spina bifida. The reality is that the vast majority of kids who are born with spina bifida do not get operated on by pediatric neurosurgeons. In fact, they're lucky if they get operated by a neurosurgeon at all. Oftentimes, it's a general surgeon or medical officer, or even an unqualified clinical officer who is working in an underserviced area. So we really need to make sure that we get word out way beyond pediatric neurosurgery in terms of how to manage these children. And I think another really important perspective for this audience, and I think for all of my colleagues across Africa, is that the children, in fact, are in our two continents. Currently, Asia is far and away the highest population of children around the world. But the population of children in Africa is catching up, and certainly by 2100, there are going to be as many children in Africa as Asia. And it's, I think, a really existential issue for pediatric organizations to recognize that the places where they spend their time and often spend their resources are often not the places where the children are, and that needs to change. Okay, so let me talk about open dysraphism or myelomeningocele. So I think every single neurosurgeon in this webinar will be familiar with a myelomeningocele. I think you'll all have seen and probably operated on many of these. They present many challenges. As I said, commonest birth defect involving a CNS, preventable. Antenatal diagnosis is a reality in most developed countries. But in many countries across Asia and Africa, that's a long distant dream to actually make the diagnosis antenatally. And that obviously, if you can't make the diagnosis antenatally, then any fetal intervention is not really going to be possible. The single most important issue in terms of neurosurgical care is how we manage these kids when they're born, and to strive for early closure. I'm going to talk about a few of the long-term complications that can develop, but also really important to stress the importance of multidisciplinary care in determining a good quality of life. And part of that is the transition of care from childhood into adulthood through the rocky and often stormy time of adolescence, which is difficult enough for all of us, but even harder if you've got a chronic medical condition. So just to quickly summarize the different dysraphic conditions, as I'm sure you all know, you either have cranial or spinal dysraphism. Cranial dysraphism can either be open in terms of anencephaly, and almost never is that of any neurosurgical relevance. Closed cranial dysraphism or encephalocele often does present to a neurosurgeon. But the focus today is spinal dysraphism, either open or closed. The embryology, I'm not going to go into too much detail about the embryology, but it's interesting that there are these really two different processes, the primary neurulation and secondary neurulation. And these different abnormalities relate in different ways to abnormalities of either of those two processes. So one of the intriguing things about open dysraphism or myelomeningocele is that there's a massive variation in the appearance of these lesions, from tiny little lesions that are almost sort of disregarded, through to enormous lesions on the back that you wonder whether you can ever actually get that closed. But the one thing they all have in common is that they start at the same time, and that is at the time of neural tube closure, which is between week 3 and week 4. And one of the challenges here is that this happens before most women even know that they're pregnant. And as I said at the outset, one of the key things here is that a large percentage of spina bifida is preventable, and that's preventable, as you know, through having folic acid on board at the time of conception. And what has become apparent, and this has been replicated in countries across the world, is that if you have folic acid, either fortification of basic foodstuff or supplementation of diet, or people taking folic acid tablets every day, you can reduce the incidence of neural tube defects by around 70%. You're never going to reduce it 100%, and that's one of the interesting challenges in terms of trying to understand the pathogenesis, but you can make a really significant difference to the incidence of this condition. And as a result of that, many countries around the world have introduced food fortification. But as you'll see, this hasn't really yet had the impact it should have had in Asia. And I think that's probably the biggest challenge that we face in terms of prevention of neural tube defects, to make sure we try to limit the number of neural tube defects born in countries where the most children are born. So a number of us have been involved in efforts to get the message out there in different fora. This is a publication that was in Lancet a couple of years ago that points to the number of neural tube defects that could potentially be prevented. And as you can see, the estimate there is over 20,000 neural tube defects potentially that could be prevented in India every single year, with more substantial food fortification. Close to 15,000 neural tube defects in China, close to 5,000 neural tube defects in Bangladesh. So there's an awful lot of work to do to try to prevent these neural tube defects from happening. Happily, the World Health Organization has listened, and I'm sure many of you know that the World Health Assembly last year passed some recommendations that actually really encourage governments to pay attention to this, and hopefully we as neurosurgeons will get behind this, make a difference. And I just wanted to mention that this publication, some of you may have seen, that came out of Ethiopia a few years ago, that really I think highlights the fact that it's not just about folic acid, but there are other factors that clearly play a role. And this paper reported a massive increase in the incidence of neural tube defects. As you can see, over 130 per 10,000 births in this particular part of Ethiopia, that obviously was related to some environmental factor that came into play. So what you've then got to try and figure out is what the relationship is between this obviously environmental factor of a vitamin and all the other environmental factors such as diabetes and obesity and valproic acid and other teratogenic drugs, and the different genetic factors that come into play. And then the way in which these environmental factors and genetic variations can interact through epigenetic regulation. For those of you interested, I'd really encourage you to find this paper by a group in the US. Rick Fennell, one of the co-authors, has spent a lifetime trying to figure out the genetics of neural tube defects. And it's a really nice explanation of how these different factors tend to interact. And if you want to kind of really get an understanding of why this condition is so difficult, I just want to show this video. So that this shows from Lee Niswander's group the early closure of the neural tube in a mouse embryo. And you can see this is a very complex kind of three-dimensional process. And it's hardly surprising that it's a really complex process. It's preserved throughout evolution, as you can see, comparing humans and mice. But there are a lot of different genes that come into play and a lot of different mechanisms. And I think that really is an important part of trying to understand why it's been so difficult to try and figure this out. On the face of it, it should be simple. We know that there's one very powerful factor that plays a role, and that's the folic acid levels. But actually trying to work out what exactly the basis has so far been an elusive goal. And I think just to take one sentence out of this paper that, as I say, I really recommend to you. They write, given the complex genetic architecture underlying neural tube defect pathology and the way in which that architecture interacts dynamically with environmental factor, further prevention initiatives will undoubtedly require precision medicine strategies that utilize the power of human genomics and modern tools for assessing genetic risk factors. So this is a really dynamic and fast-moving field to be working at. And if any interested, we'd encourage you to pursue any interest you have in this. And just to end off with one more point related to folic acid. So it's not an all or nothing thing. And it really does seem, and if you're interested, you could pull up this paper by Lee and Gleason from San Diego, that if you have some folic acid on board, it will probably reduce the severity of neural defect if it doesn't prevent it altogether. So it definitely has benefits, even if a baby is born with a neural tube defect. One of the other fascinating things, and I think Prof. DeRocco can maybe reflect on this at the end, is the incredible evolution in the sort of philosophies of management from a very nihilistic approach in the 50s right through to the 70s, the so-called selective treatment, which essentially was euthanasia, through to explicit euthanasia as reflected in the Groningen Protocol. through to the pendulum kind of swinging almost 180 degrees to the other side of a really aggressive approach to fetal interventions and maternal fetal surgery, which I think for many of us in this webinar is just an impossible target, because we just can't even get the diagnosis made before birth. So just one slide on maternal fetal surgery. So it certainly was popularized after the MOM study published in the New England Journal about 10 years ago. And there are many centers now in well-resourced countries that are offering this. For me, the jury is still out. I'm not completely convinced that the benefit is that substantial. And certainly if the amount of effort put into fetal surgery was put into food fortification, I think that might have a pretty significant impact. And I think there's a really important health equity angle here as well, in that the massive resources that go into fetal surgery, as I say, could well play a very powerful role in actually preventing the condition in the first place. And I think many of you from less resourced countries will be familiar with these kids that come to your hospital 3, 4, 5 months down the line after birth, and they haven't been operated. The placoder's epithelialized, and those are lucky ones. For those who are not so lucky, where the myelin meningeal has got infected, they're really in a terrible state. And often in that situation, they've ended up with chronic ventriculitis, and you've really missed the boat in terms of trying to help these kids. And you end up with a really ghastly situation. So it's much better to obviously be able to make the diagnosis early, to get the back closed. If the back does epithelialize, then you still have a chance of removing that sac, and which is often necessary just from a comfort point of view. But if the lesions become infected, there's often very little you can do. So in terms of the operation, just to acknowledge my mentor, Jonathan Peter, who taught me all the principles that I'm telling you about today. So the surgery is really straightforward, and really should seldom take more than an hour or so. With a newborn baby, obviously, a skillful anesthetist and a warm operating theatre is important. It's really handy to have an assistant, although oftentimes you're doing these cases in the middle of the night. And it's really about visualizing the closure that's going to work anatomically. And I don't think there are any kind of preconceived rules about that. You're operating on a newborn baby. They're very forgiving. They're going to do their best to heal, but you need to look after them and handle the tissues carefully, and be very, very cautious about using bipolar and other sort of traumatic aspects of surgery. And you can probably actually control most bleeding just by using a hemostat rather than actually using bipolar. Try to close the back in at least 3 layers. But the most important layer is the dura. And I always tell our residents, if you get the dura closed, you're literally home and dry. And even if the back breaks down, if the dura doesn't break down and you don't get a CSF leak, then the baby's going to be fine. Do not close the skin under tension. And if the skin doesn't come together nicely, you can undermine laterally, and in fact, you can undermine all the way through to the umbilicus in order to mobilize the skin. And then obviously pay attention to analgesia post-op. So there's a reference there. It's an old paper from 30 years ago, but still, I think the basic principles of how you get the back closed in myelin meningeal, that hasn't changed over many years. So as Professor Dorocco said, it's very much about long-term management and multidisciplinary follow-up. So there are a few other things we need to think about as neurosurgeons, like managing hydrocephalus, recognizing the possibility of a Chiari malformation and a tethered cord. But more important, really, than neurosurgeons going forward is the urological management. And that's not just about bladder, but also about sexuality. As these children go through adolescence into adulthood, it's really important not to disregard that. And for those who need the help of a stoma therapist to obviously provide that kind of expertise. Orthopedic surgeons play an important role in their various skeletal deformities that they need to help manage. Developmental pediatrics, if you're lucky, and psychology, and then obviously managing transition through adolescence into adulthood. And I think in terms of quality of life, probably the most important thing that we can try to achieve is social continence. And you can achieve that with clean intermittent catheterization. And even children living in the most basic, most humble circumstances can be socially continent due to clean intermittent catheterization. And if Nobel Prizes were handed out for things that were really useful, I think the guy who introduced clean intermittent catheterization would have got a Nobel Prize. It's an amazing intervention. It makes such a difference to people's quality of life. So just a couple of cases. So here's a 4-year-old girl, had her back closed shortly after birth, shunt inserted at day 6, and comes back to clinic now complaining of back pain, absolutely no other symptoms. And as you can see, despite the fact she's got no other symptoms, a spectacular syrinx, and we were kind of debating whether we should just ignore this or do something about it. When she came back 2 weeks later, complaining of headache now with an obvious 6th nerve palsy. And despite the fact her shunt had appeared normal 2 weeks ago, it was her shunt. And I think one of the key messages here with myelomeningocele, when these kids deteriorate, it's almost always the shunt. So when you're faced with neurological deterioration in a patient with myelomeningocele, there are a bunch of things you need to think about. You need to think about shunt malfunction. You need to think about urinary tract infections. You need to think about Chiari malformations, rhingomyelia. You need to consider secondary tethering. You need to make sure there isn't severe progressive scoliosis. You need to think about latex allergy. But in reality, it's usually the shunt, or the shunts, maybe the shunt again, or the shunt, and then maybe a urinary tract infection, and then maybe something else. So almost always, sadly, when there's kids deteriorate, it's a shunt. So we can put our heads in the sand and try and deny it, but usually the kid needs a shunt revision. So just to show one other variation on the theme, here's an 8-month-old girl, myelomeningocele close at birth, comes back with worsening apnea. And in this kid, the shunt was working. So my colleague, Nico Enslin, was managing her. And then eventually, actually, Nico got an MRI scan, and she had such rapidly developing bulbar palsy that, in fact, the anesthetists were unable to extubate her following the MRI scan. So Nico took her to theatre, and in this case, the problem we felt was, in fact, a Chiari malformation. What's really important to emphasize is that a Chiari decompression for myelomeningocele is a cervical laminectomy. It's not a suboccipital decompression. And you need to be really, really careful, because almost always the torcular is sitting at the foramen magnum. And if you actually do a posterior fossa decompression like you would for a Chiari 1 and open the dura into the posterior fossa, you may have a very early end to operation, because if you open the torcular, it's obviously game over in a small baby. So you need to be very, very careful how you open the dura and how far rostrally you go. In our place, it's very much just about doing a cervical laminectomy in the few cases we do. Opening the dura, taking down the adhesions, and then putting a dural graft in. And if you do that, you can have a very good outcome in the very rare patient who is symptomatic from a Chiari malformation. So if you're looking at the outcome, I think, Etzia, I think you spent time in Chicago, didn't you, some years ago? That's pretty much the gold standard. I think David McClone was probably the person who did more than anybody to really to get people to pay attention to managing these children well. And certainly that series from Chicago demonstrated that you can have a really good outcome. As you can see, 2/3 of kids who survived had, in fact, were able to go to normal schools. They still had lots of shunt problems, and they still had the sort of progressive decline in ambulation through adolescence, but that's not a big deal. You can have a very good quality of life sitting in a wheelchair, and oftentimes it's better to conserve your energy and sit in a wheelchair than struggle along walking abnormally. But the take-home message here is you can achieve a good quality of life. And I think getting involved in these community organizations, we've got a great organization in Cape Town called ASBAR that kind of provides all the other support that we can't as neurosurgeons. And we've written up and published our sort of multidisciplinary approach, if any of you are interested in that. Okay, so that's open spinal dysraphism or myelomeningocele, where what you're dealing with is sort of apparent on the surface. Closed spinal dysraphism is often a lot more subtle. It can be a little bit like looking for a leopard in a tree. So just like looking for leopard, you have to go by kind of external landmarks, and sometimes they can be quite subtle, but almost always there is some cutaneous abnormality, and that will usually lead to an MRI scan where the diagnosis gets made. And the key pathophysiological issue here is tethering of the spinal cord. So as you can see in that MRI scan, when the spinal cord runs down below kind of L2-3, you can end up in a situation where the cord is so-called tethered, and progressive traction on the cord causes damage, which eventually causes neurological impairment. So for those of you who are familiar with the Journal of Korean Neurosurgical Society, there was a magnificent series of papers published 3 or 4 years ago. Professor Seung-Kyu Kim, who is editor of the pediatric issue of that journal, convened a series of papers by Dakling Pang. Professor Wang wrote a really beautiful editorial sort of reflecting on what he had seen as 2 decades of evolution and thinking, and what he termed the era of dynamic advancement in spinal dysraphism. And for those who are interested, I'd really strongly recommend you read these papers. They give a really beautiful overview of the changing philosophy of management of closed spinal dysraphism, different forms of dysraphism. But for me, there are really 3 key questions. And the first is whether all lipoma, and maybe this is a stupid question, because some people would say for sure they all need to be operated. But I think in an asymptomatic patient, you've really got to be convinced that the outcome of your surgery, and it's not the outcome of Dakling Pang's surgery or somebody else's surgery, the outcome of your surgery is going to beat the natural history. And I think one of the other important things is to be very clear that, in fact, the patient is asymptomatic. Because as I said at the outset, if you don't examine or you don't assess children, particularly small babies, thoroughly, it can be very easy to miss a deficit and to call the patient asymptomatic, when in fact that's not the case. So the second question is, what are the goals of surgery? And clearly in this case, your primary goal has to be to actually untether the cord adequately. And then thirdly, what do you do about retethering? And retethering needs to be kind of defined either clinically or radiologically. And one of the things that I really love about the approach that Dakling Pang has taught us is that if you untether the cord adequately, as he has advocated, it's very clear that the cord is untethered. And then if you on subsequent imaging can see the cord is now radiologically retethered, and that is perhaps combined with some clinical features of retethering, then you may have a case for reoperating. But if you haven't untethered the cord adequately to begin with, it's just impossible to interpret those post-op scans. And of course, if the patient does have late deterioration, you have to think about whether the deterioration is in fact due to tethering, or whether this is just the natural history of the abnormality that the child was born with. And certainly, there have been a number of neurosurgeons over the years that have written about that. That in fact, you need to be very, very clear that the deterioration is due to kind of features, and usually you'll find upper neuron features if there's tethering that you can correct with a repeat operation. If it's just an unfolding of the natural history of the condition, then I'm afraid your surgery is not going to change that. So these are the two papers that changed the field, published by Dr. Pang in 2009. In fact, I first heard him present this work in Nagoya when he spoke at the interim meeting of the WFNS in Nagoya, and in 2007, I think it was, and spoke about the new approach that he was due to publish. And certainly for me, this has been one of the most profound innovations in pediatric neurosurgery over the course. The rationale for this so-called radical approach to plotting the natural history of this total resection group, as you can see on the top, versus partial resection of the lipoma. And Professor Dorocco will remember at that meeting in Chile, there was a sensational presentation by Elaine Pierre-Kahn from the group at NECA that really rocked the pediatric neurosurgical community, because they looked very honestly at their long-term follow-up and reported that, in fact, the long-term outcomes of surgery for lipomas were not that fantastic. And that's, in the fullness of time, really just reflected the fact that they, like everybody else, was doing partial resections. And a total resection gives you a very different natural history. So one of the important things about this technique is that it's really not that complicated. And if you pay attention to the basics, I think pretty much any well-trained pediatric neurosurgeon can apply this surgical technique. One of the important principles is to have a very wide exposure. If your exposure is not wide enough, then you're not going to see the nerve roots, you're going to get lost, and you're not going to do the operation properly. With that wide exposure, you can also then adequately detach the lipoma from the dura, and that then enables you to do the intraoperative mapping that enables you to do this operation safely. And intraoperative neurophysiology is pretty mandatory for doing this operation. One of the key anatomical features is the so-called white plane that Dr. Pang has described. And that's a very real entity. As you dissect down kind of through the lipoma and find that interface between the lipoma and the spinal cord, you find this very well-defined fibrous sort of network that you can then dissect with your micro scissors. If you're using a Kuzo or a laser or something else, you don't really appreciate the consistency of that white plane. But I think using a micro scissors actually makes it quite easy to then follow the white plane and avoid going into the spinal cord, which obviously is the thing you want to avoid. Then once you've resected the lipoma, you try and restore what nature was not able to do by kind of trying to neurulate the spinal cord to really just reduce the bulk of the spinal cord. And then the final feature is the capacious dural graft. And if you can get all that right, you've got a very good chance of a very good long-term outcome here with no deterioration. So for those of you who are looking for some more details on the technical aspects of the operation, there's a very, very extremely detailed, even for Dr. Pang, extremely detailed review article published in this Japanese journal that I'm sure you can access online. And it goes through every single step with these beautiful photographs that, as you can see there, shows very clearly where the interface is between the lipoma and away from the spinal, wanting to neurulate the spinal cord by sort of bringing those two peel edges together. And the role of the intraoperative mapping here is all of these little fibers are running laterally. As you stimulate them, you can identify those that are involved in kind of normal neural pathways and are clearly functional nerves versus those that are just fibrous bands that you can cut. Once you've neurulated, you can see if you compare that to the original scan, you've got rid of that great big lipoma over there, and you've got this beautifully neurulated spinal cord, which you've kind of restored to almost what it should look like. And as I say, kind of we're talking about something that pretty much any well-trained neurosurgeon can do if you pay attention to it. So here's just one example of one of the early kids that we did. You can see this child was deteriorating, had brisk knee jerks. So in my view, that's a really good indication of a tethered cord that you need to do something about. You can see the lipoma over here, not only causing traction on the cord, but actually compressing the lower part of the conus. And then with surgery, you can see we've managed to untether the cord. The tiny little bit of fat still stuck on the conus, but the conus is lying nice and free in this very capacious kind of CSF sac. Okay, so over time, more and more groups have started to report their findings. This is a nice paper from Great Ormond Street, where those of you who know Dr. Pang will know that in fact he's now relocated to London. But Dominic Thompson at Great Ormond Street has been doing this procedure for a number of years and recently reported in child's nervous system, of course, ETSIO, their experience with radical resection of lipomas. So just to end off with a couple of words about the ISBN. So any of you out there who are interested in pediatric neurosurgery, please consider joining the ISBN. But even if you're not a member of the ISBN, you can access this resource online. The current president of the ISBN is Shmi Constantini. who has done an amazing job, really sort of supercharging all of the different online resources that the ISBN has made available to improve the care of children with neuropsychical conditions. And of course, if you do join the ISBN, you get access to Professor DeRocco, the journal that Professor DeRocco has edited for many, many years, Child's Nervous System, which is an added bonus. So on that note, thank you very much. That's just a photograph from Cape Town, the other end of Africa from where I am now. There's my email address if any of you want to get in touch. And of course, sincere thank you to all my colleagues back home who are doing the work while I'm doing this talk. That's just a photo I've taken at the World Congress that we had the honor of hosting in Cape Town the end of last year. Just some of our alumni from around the world that were in Cape Town for the Congress. So on that note, thank you very much, and I look forward to questions or comments, Professor DeRocco.
Thank you. It was very impressive, and I think that you demonstrate with this kind of a presentation the change attitude of the neurosurgeon that you define as advocate for the spinal defects. And I think it's true. It's not so relevant probably what we do surgically, because this can be done in most of the countries, while the other aspects of the care cannot be achieved. And you said, for example, you made a diagram with so many specialists that are involved in the post-operative care. So my question to you is, we should aim to have the patients know all the possibility of the cares going from one specialist or to the other, or we have to convince the politicians to create special departments for spinal dysraphism, where the patient can find all what they need. I don't know if it's my questions. So the role of the association, the role of the multi-specialist clinic, how we can push for that.
So I think that there are two aspects to that. So you will have seen, as I have over a sense, multidisciplinary, the concept of it, it's incredibly difficult to sustain that. It takes real commitment on the part of all the different specialists involved. And I think it is important, obviously, to advocate for resources to run clinics like that. But I think a much more important thing, and probably a more effective approach, is to also kind of harness the community and families, to teach families what is required. Things like clean intermittent catheterization, as I said, can be done under the most simple circumstances. And obviously, it's really important if you've got a urologist to continue following up the kid. But more often than not, particularly in resource-limited settings, it may cost a lot of money. You know, people living in rural areas have to travel a long way to go into clinics, and you need to make sure you give those patients and their families the best possible value you can when they do come to a hospital. And these educating community health workers and other people actually provide the care that's required.
Fortunately, we lost most of your answer because of technical problems. But the second question, which is related to the first one, is about the transition. When the children become adults, how they can find the same attention that they had when they were children, when they become adults.
So that's a very difficult one to answer, in that it really depends on individual specialists being motivated to kind of build a bridge to their adult colleagues. And I don't think there's a model that, I mean, so in our department, pediatric neurosurgery and adult neurosurgery part of the same department. So that transition is easy. But I think in many cases where you have a children's hospital that is completely separate to the adult service, it's much harder to make that effective transition happen. And I think one of the other important things is that neurosurgeons play very little role once, fortunately, I mean, thank goodness, unless these kids end up as adults having multiple shunt problems. We aren't really part of the picture. It's very much the urologists and to some extent the orthopedic surgeons, and then the psychologists and maybe the renal physicians and people like that play a role. But we often the people that know the patients best because we see them at the time they're born, and then we then need to play a role in sort of making sure that transition actually happens.
Another question that came from one of your slides, the Texas experience with a prenatal treatment of malmeningocele. I don't understand why they continue to use figures about the incidence of hydrocephalus that were good 40 years ago. In this slide, they said that you have 82% hydrocephalus in children operated after birth versus 40% if they are operated before. But we know that nowadays the children that need shunt are no more than 50-60%, because we are now reluctant to go with the shunt, so we try to see if they can get rid of the shunt when we wait for some time. In the same way, I think that those that operate children before birth are reluctant to put a shunt after. So at the end, I don't think that there is this big difference in hydrocephalus incidence with a prenatal and postnatal care. About the PRE2, this is true. The incidence is a lot less, but most children with a PRE2 don't have symptoms for in their life, and some of them, a good percentage, show a decrease of a PRE2 during life when they go well. So again, I'm a little skeptic about the prenatal treatment, especially because when it's not done, the families can believe that they lost a great opportunity if they were not operated before birth. And I think that this sentiment should not be increased, giving a fake percentage. You remember at the beginning they say that they had an improvement in the palsy, a high level of paralysis of the legs, that now they suggest an improvement in the need of orthosis. So they corrected. But at the beginning, it seems that they could improve the level of the malmeningocele, which had no sense, obviously.
There is some issues with his internet.
We are very unlucky with question and answer.
Let's wait for him for 5-10 minutes, maybe he'll join us back. But I'd like to ask to Prof. Dirocco as well, what is the optimum timing of repair in an open myelomeningocele, according to you?
Yeah, when we started, it was mandatory to operate in the first 24 hours after birth, because we believed that in this way we could decrease the incidence of infections. Nowadays, we are a little more flexible. We can wait 48 hours or even 1 or 2 days. But I think that it's still important to operate in the first days after birth, is decrease the incidence of infection.
Most of the time it is not possible in LMICs, where usually in India or maybe South Africa, or where in the government institutions there is a big challenge to mobilize them in first 24 hours. So we do as early as possible, but we have no consensus about what is the optimum time. Prof. Pijan has joined us back. Thank you very much for joining us back, Prof. Pijan.
What I think very important from the presentation of Professor Fregel is the emphasis on prevention. I think this is the most important part of the experience we gained. And I can understand why it's not done, even in counts that are in progression, because it costs very few money to add some acid folic to the wheel and so on. At the same time, when there is a social problem like the marriage between cousins that are quite diffuse in Arabic countries, I saw in my experience in Kuwait, why we cannot convince the people about this risk? I think that we need to convince politicians to listen to us. And Grant Flieger was doing a good job in emphasizing this.
If there are any other questions from the panel, Michael.
Okay. Thank you. Thank you, Prof. Figan, for your nice presentation. Thank you, Professor Dediko. I'm Michael from Ethiopia. So I have two questions. So what's the maximum limits of doing kyphectomy during myelomeningocele repair? So in some patients with myelomeningocele, they present with kyphosis, and it will be difficult to close the skin during the repair. What's your recommendation about kyphectomy during the MMC repair? The second question is about limited dorsal myeloschisis. So do you do always MRI for children with limited dorsal myeloschisis and surgical techniques? So do you do laminectomy to see the place of the stalk attachment to the cord, or do you just manage it with the small opening that's due to the defects? Thank you.
Mikhail, nice to see you again. Thank you for those questions. So I'm afraid I didn't quite get the second question. It came through very poorly. Would you mind repeating the second question?
It's about limited dorsal myeloschisis. So children with limited dorsal myeloschisis, so they have the sac and neurovascular stalk attaching from the sac to the cord, and the bony defect is small. They have a small bony defect, and this stalk goes attached to the cord. So on some papers I've seen that they only remove the stalk and they don't do laminectomy. On some papers it's recommended to do laminectomy and follow the stalk attaching to the cord and do proper repair. I just want to ask, have your opinion on that.
Yeah, I'm afraid I couldn't get all that, but just let me answer that first, and then I'll talk about the kyphectomy. So in terms of LDM, or limited dorsal myeloschisis, the only important thing is to make sure you've untethered the cord, so identifying that point at which it inserts into the cord. And sometimes there can be an associated dermal sinus tract as well, or a dermoid. So you need to look out for other dysraphic abnormalities like that. But I'm afraid I couldn't get all of your question. But I mean, in LDM, you need to. I mean, certainly. So I guess I was going to say you have to have an MRI scan, but these lesions were operated on in the days before MRI. They weren't often identified, fully, and people often kind of, I guess, miss the tethering element. But there was clearly a dysraphic abnormality. I mean, it's got a very characteristic appearance. So people were doing operations, but I think if I think back to my early days of my career, before Pang really sort of made us think systematically about this condition. I think the surgery was a bit more sort of random, but now the goal very much is, we know that there's that tethering element. You just need to find it and make sure you've untethered the cord. In terms of kyphectomy, so usually, I mean, it's incredibly unusual in my experience that you have to actually formally do a kyphectomy. But what you can sometimes have is incredibly exuberant lateral masses, and then you just get a bone nibbler and raunchy that away. And often in those cases, you have when you do have that situation, oftentimes there'll be very, very poor distal neurological function. So there's less concern about preserving what neural elements there are as to kind of making sure you can get adequate closure. And I find just using a bone raunchy, sort of taking down those big knobs of bone down as low as the cord, and then mobilizing the skin fully. That's all you need to do. And a formal kyphectomy, I've never had to kind of go and take away sort of ventral bone and kind of try and reconstruct the spine. I don't think one could actually in a newborn. So I think when people talk about a kyphectomy, essentially what they're doing is taking away the sort of the posterior elements that you can do quite easily with a bone nibbler. Have you had a different experience?
So I've usually when I do, like you said, I take out the lateral mass, the bony mass with ronger, and do the skin closures. Usually, if it's difficult. But on one video, I saw they took the anterior vertebral bone and stitch it with silk and put the patient on lumbar brace in infant. It's not in neonate, but in infants. But I haven't done that and I haven't seen my experience. But I've done a few kyphectomy with the procedure that you described with ronger and take out the lateral mass, the bony mass on the lateral side. Usually I do that whenever there is difficulty in closing the skin. So where I am working, there is no plastic surgeons. So I have to do the skin flaps, the limbar flaps or rotational flaps by myself. So whenever there is difficulties.
Okay. So can I comment on that? So I mentioned my mentor, Professor Peter, who Professor Duracco will remember well. So Professor Peter used to keep things very simple. And that was what I loved about his approach to surgery. And he had a very good partnership with plastic surgery doing craniofacial surgery. But when it came to myelomeningocele, the number one rule was to make sure the plastic surgeon stayed in the tea room. They could give you advice, but you don't want complicated plastic surgical flaps in these babies. It's unnecessary. If you mobilize the skin adequately, and literally you can mobilize all the way around to the umbilicus, there's plenty of skin. I think it's almost inconceivable if you do that you need any sort of complicated flaps. So you're much better off, and the patient's much better off having just you in the operating room. So don't feel badly about that. You can get the back closed. You don't need someone else.
Thank you.
Thank you very much, Michael. I would like to comment that we always have a closure team different from the resecting team in our university hospital that I work. We keep them when the closure of the dura is over, that it's their turn to take over, because we do a lot of cases every week mostly. So I don't know how it is really scary for me to even hear that you can mobilize the skin up to the umbilicus. So maybe someday we can come and learn from you, Prof. Vigan, the techniques of closure too. Thank you very much. Any other comments from Prof. Rupesh or Prof.
Yes. I have one question to Professor Graham Hagen. Is there any role of sacral nerve stimulation in a patient who has bladder bubble dysfunction after surgery? Does it anywhere work as a part of rehabilitation?
That's a fantastic question. So you're talking about sort of older children and adults trying to improve their bladder function. Yeah. I mean that is really the biggest challenge in trying to provide a sort of better quality of life. As I mentioned, the fact that a lot of these individuals kind of just stop walking. I mean, the incidence of ambulation drops steadily through adolescence and into adulthood. And that really isn't a big quality of life issue. And oftentimes it's just easier to be in a wheelchair and conserve the energy and not struggle to walk, which can be such an effort. But if we could really improve bladder function, it would make a massive difference. And so far, nothing really terribly effective has been introduced. But I'm very optimistic. Looking at the work that's being done now, particularly in the area of neuromodulation. Obviously, we're talking extreme high-end technology at the moment, but I think a lot of the work for those of you at the World Congress last year, we had that beautiful work presented from Switzerland. Looking at different brain-computer interfaces and these different neuromodulation strategies that maybe over time are going to be able to repair the central nervous system. So I think in 30 years' time, I hope the answer to your question will be yes. At the moment, sadly, it's not. But I think it's one of the most exciting and fast-moving aspects of neurosurgery. And I think it'll make a big difference, not just for people with spinal cord injury, but people with spinal cord injury.
No, I have one question about acoustic, if I can. Because Professor, you showed that in 23 you had a bigger reduction in complications compared to the previous period. But the pathology did not change. The patients were the same. Probably you didn't change the technique too. So how you explain this improvement in treatment, in the results? Because you decide not to be very aggressive in the worst case?
Because when we realized the high key risks of the damage to the facial nerve functions. So when we realized the position of the facial nerve in the upper polar and the shape of the umbrella shape of the facial nerve when we face during the operations. So we pay much attention meticulous maneuvers to do the operation during the operations. So the technique has been improved a lot. The strategies to do to remove the giant acoustic neuroma is slightly improved, especially for the high risk key factors. When we face
所以，当我们意识到面神经功能损伤的高风险时，我们
when we what I mentioned, I don't know. Can you follow me? Because we do a lot of cases, so the skills improved a lot when we dissect the facial nerve and recognize the risk. So we are improved. We improved our skill For examples, if we for the facial nerve in the polar upolars unscattered, so we will left some thin and remnant thin phase in the facial nerve. That's the one. The second, when we open the IAC canals and find earlier the facial nerve, the location of the facial nerve. So we are quite clear how to remove this the tumor efficiency. So in our team, the coordinated together is so different in 2023 and compared with the previous 6 years. It's quite different, and the timing surgery is become short and short, and the outcomes become better and better.
We can wind up this session and hear the concluding remarks from Prof. Diroko.
We can stop now.
Okay, Prof. Thank you very much. So in that case, I'll wind this up officially. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kata, I would like to thank both the speakers of today, Professor Lou Meking and Prof. Graham Fegan, and also the chairs, Prof. Rupesh Kumar and Prof. Concesio Diroko, for the time and support for the ACNS webinars. Very special thanks to Prof. Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, we have around 440 people who have logged in through different channels. And special thanks to my co-host Liu Bun Seng, who joined us from Malaysia. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.